This is a screencast about imaging the pleural space, sponsored by the Society of Thoracic Radiology. By the end of this talk, you should be able to describe the two layers of pleura, list imaging tools you can use to image the pleura, describe how patient position influences the appearance of pleural fluid and pleural air, list imaging features used to diagnose pneumothorax on chest x-ray, describe the significance of tension pneumothorax, and state which pleural features suggest malignancy. First things first, let's discuss anatomy. Remember, you have two layers of pleura. You have the parietal layer, which lines the thoracic cavity, and then you have the visceral layer, which surrounds and invests the lung. It's this visceral layer which surrounds each lobe, and in doing so, invaginates into those fissural spaces, creating your fissures. Both the pleural reflections meet at the hilum. In terms of the pleura, geography does matter, so keep in mind there are descriptive terms you can use to identify where you are, or what you're talking about in terms of the pleura, specifically the parietal pleura. The most important thing to remember is the costophrenic angle. That's your most important landmark or an anatomic feature regarding the pleura. The costophrenic angle is identified at both lateral lung bases on the frontal view, and it's located posteriorly on the lateral view. And in a normal patient, these should be nice, sharp, V-shaped spaces. In terms of structure and function, the pleural space is a potential space, so there may be slightly negative pressure depending on the level of inspiration, but overall, this is designed to be a friction-free space which allows the lung to move as you breathe. Also, remember, the thoracic cavity is a fixed space. Those bones can only move so much, and therefore, the pleural space is also a fixed space. So if you have abnormal fluid or air or cells in that pleural space, something has to give. There's going to be compression of other things like the lung nearby. In terms of imaging, you have plenty of options. So you may start with x-rays like frontal and lateral views, or maybe Decubitus views, which we'll look at in a second. You could consider CT or MRI. Usually with contrast is better than without contrast. Or if you're thinking about some sort of a procedure like a thoracentesis, maybe ultrasound is the way to go. Just keep in mind, nothing's perfect. There's always slight differences in imaging modality. There's differences in radiation. There's also differences in cost and effort it takes to perform the exam. So just keep in mind your patient, the indication for imaging, and just think about all these features. Try to pick the best test you can. In terms of fluid in the pleural space, that's what we're talking about, pleural effusion. But it's really non-specific. What are we talking about? Pleural effusion usually infers either transudative or exudative fluid. Either perhaps someone in CHF, maybe someone with a really advanced pneumonia, something like that. Keep in mind blood in the pleural space, if that's what you know is there and that's what you're expecting. That phrase, the best phrase to use is hemothorax. And in those instances, describing blood in the pleural space as pleural effusion may not be the best way to go. Anyway, consider the minimum volume of fluid that may be visible on some of these imaging modalities. Consider a frontal PA chest x-ray. Think about where that fluid will go at the costophrenic angles. On a lateral view, you need even less fluid before it's visible at the posterior costophrenic angles. If someone's laying down flat and there's a supine x-ray, there you need much more fluid layering dependently before you can reliably see it. And of course, a CAT scan, you'll be able to see a much smaller volume with much higher level of detail. All right, so again, consider small effusion on frontal and lateral views. Where will that fluid go? It should come dependently down to the base of the chest, and the first thing we're probably going to see is blunting of the costophrenic angles. So here's a frontal x-ray. Look at the costophrenic angles. They're not as sharp as that last patient we just saw. They're a little blunted. I don't really see a nice V shape, especially on the left side. So we're suspecting small effusions. Here's the lateral view. Now, take a look at the posterior aspect of the chest on the lateral view. These costophrenic angles are really not even visible. These nice sharp V's of lucency, we don't see them. They're filled in, and then there's this layer here. You could almost argue there's a little bit of a meniscus sign back here. So again, small effusions, we know that's what we're looking at. It seems like the fluid is actually more than we were expecting just based on the frontal view. Here's a CT scan with small effusion on the left side. So just keep in mind the patient's laying down flat on the CT table. And so fluid is going to track dependently to the base of the chest. It's going to get as low as it can because of gravity. So we have an axial view and a coronal view. And here's a sagittal view. Again, the patient's still laying down flat on the table. A Decubitus chest x-ray could be used if you're not quite sure there is fluid at all. In this case, the Decubitus view is named for the side that's down. So in this instance, we see a left lateral Decubitus view. The left side is down, and perhaps people weren't sure if there was a pleural effusion or not. But what we see here is evidence of pleural effusion. You see thickened lateral pleura, and that thickened band between the air and, I'm going to call it opacity interface, and the ribs is the layering fluid. So in this case, the Decubitus view seemed to help. Here's a patient with a larger effusion on the right side, at least a moderate or large effusion. There may even be a little bit of fluid on the left, but the findings here are really located on the right side. Here's someone with a large pleural effusion, no doubt about it. This fluid fills the space of the left hemithorax, and so we have a whiteout or an opacified left hemithorax. The thing about this is it's pushing the harda mediastinum over to the right. This effusion is so big that it's exerting mass effect upon those central structures. Here's a coronal view, not the same patient, but similar pathology. Large left pleural effusion, the left lung is atelectatic, and look at the heart. It's being pushed towards the right hemithorax. All right, so in terms of dependent fluid, just remember where fluid's going to go. It may seem like common sense, but just think about it. Hear me out. In an upright patient, simple layering fluid is going to fall dependently. Gravity is in effect. The fluid goes to the base of the chest. Now, consider if the patient is recumbent, maybe at a 45-degree angle, maybe an inpatient in a hospital bed. At a 45-degree angle, that fluid is still going to track as low as it can get. It's going to track dependently to the base of the chest, but the most dependent aspect of the chest is sort of oblique in that 45-degree position. And keep in mind, when you perform a portable x-ray, for example, the x-ray is being introduced directly above the patient. So when you look at the image, you may not realize the patient's at 45 degrees. Think about how that fluid might look differently. And then compare this to a supine patient laying flat. That fluid's going to layer dependently along the posterior margin of the chest, sort of fanned out along the dependent surface. And so you're going to get this widespread haziness. Again, you may not realize the patient's supine if you're looking at the x-ray. All right, so here's an example of that semi-upright or 45-degree patient we just mentioned. You're going to see a gradient haze approaching both lung bases. And in a patient like this, if you see the image on your screen, that's a great example of layering pleural effusion. That fluid also results in a little bit of compressive atelectasis of the adjacent lung, but that gradient haziness, as you get closer to the lung bases, things get whiter. That's a characteristic feature of layering effusions in someone who's not exactly upright. Here's someone who's laying down flat. Look at the right side of the chest. Look at that haze. And if you look at the apex, you can see there's apical pleural thickening and mediastinal pleural thickening. If you can think about it in another way, consider this CT scan, a sagittal view at the bottom corner of your screen. It's sort of the same thing. A dependent patient, fluid's going to layer down to the base as far as it can get. That's what it's going to look like on a portable x-ray. Sometimes if something's a simple layering pleural effusion, it's just as simple as sitting the patient upright and that fluid will move. So the patient we saw with a supine pleural effusion on the left side of your screen suddenly sat upright, gave it a few seconds, and all the fluid dropped down to the base of the chest. So that fluid can move. It's not fixed in any space. Now let's change it up a little bit. Loculated pleural effusion. This is fluid that basically forms pockets, or we're talking about complex fluid that may contain debris or hemorrhage, and there's some level of organization, so there may be fibrin within that collection of fluid. It generally is seen in fluid that's been there a while, so there's some element of chronicity. In terms of imaging, that's when you see fluid in non-dependent locations. So something like fibrin strands or some sort of encapsulation, something's preventing that fluid from following the rule of gravity. So it's not falling down to the most dependent chest. You may see it laterally, you may see it higher than expected, you could even see it within the leaves of the fissures. Here's an X-ray, frontal and lateral view. This is someone with abnormality on the left side. So the left hemithorax is abnormal. There's a chest tube in place. Draw your attention to the left lateral lung base. And so there's probably some fluid down here. The costophrenic angle is not visible, but there's also this convex appearance laterally. That makes me think that maybe there's some loculated fluid too. If it wasn't loculated, why would it look like that? It would just be layering dependently. The corresponding CT proves our suspicion. So remember, this patient's laying down flat on the CT table. They're in a supine position, and you see loculated fluid along the mediastinal pleural margin and the costal pleural margin right here. This patient's sort of unique because if you take a good look at this, there's actually an air fluid level in this patient as well. You can see dark lucency and a clear demarcation. There's a line that separates that from more hazy opacity. That tells me that there's some air and some fluid and they're contacting one another. In this instance, it's anterior and it's medial on the left side. We're going to use this as a segue into air in the pleural space, or pneumothorax. Air in the pleural space, we're thinking about radiolucency, and this should be abutting the lung. There should be an interface between the air and the pleura, a thin white line, and this may result in varying degrees of lung atelectasis. So remember, if you're looking at an X-ray, every line has to be accounted for. Lung markings do not extend beyond the pleural margin. The pleura is contained within its own hemithorax, which seems like common sense, but a line does not cross midline and it doesn't extend beyond the thoracic cage or beyond the bones. So what does it look like? Take a look at this image. It's zoomed up a bit. It may not be completely obvious, but if you really take a look, there's a difference. There's a place where you see lung markings extending to a point, and then beyond that, you just see lucency or radiolucency. That's the pleural air. We can sort of think of an outline of the lung right here. So that's the pleura, and it's being surrounded by air with pneumothorax. So here's a patient. We weren't quite sure if this was real or not. There was suspicion of small right pneumothorax, and it looks like there's blunting of the costophrenic angle at the lateral right lung base. So maybe there was pleural fluid as well. This patient had a lateral view, which told us more about the pleural effusion. Check out that meniscus sign right there. Went for CT. So here we can see a small amount of layering fluid in the right pleural space. There's also a small amount of non-dependent air. And on coronal and sagittal views, we see this as well. Here's the sagittal view as if the patient was laying on the CT scanner table, which they are. But remember, air rises. Air isn't defined by gravity except that it's non-dependent, so air rises. And of course, why did this happen? Well, there was a rib fracture. This was actually a trauma patient. So there was air and fluid introduced into the pleural space. How about this one? Do you see the pneumothorax? It's on the left side. If you look real close, there's a thin white line, and beyond that line, you just have lucency. Here's another one. Hopefully this one's more obvious. Large left pneumothorax, significant collapse of the left lung. Here's the lateral view. It doesn't necessarily help too much. It tells us there is a little bit of fluid in that pleural space, which I guess we knew if we really paid attention to the frontal projection. One thing I want to make sure we all understand is the concept of tension pneumothorax. So that's in the setting of a large pneumothorax, a large volume of air with increased pressure upon those central structures. If there's enough pressure in there, you get movement of the heart and mediastinum away into the contralateral space. Think about it. You have contralateral shift. There's pressure upon the cardiac chambers, the great vessels like the central veins, which supply the heart with blood. And so if there's enough pressure upon those structures, you could get decreased venous return and therefore circulatory collapse. Long story short, this is an emergency, and this needs to be decompressed right away. In this patient, look at the heart border. Look how far it's being pressed into the left pleural space, or the left hemithorax, rather. The right pneumothorax is very large. Think about the midline in this patient, and then sort of think of a reference. Think about all of these normal contours. This is your superior vena cava coming down into the right atrium, your right heart border, your IVC. All of those things are really being severely compressed. Here's a tension pneumothorax on the left side. The left lung is partially atelectatic. There's a large volume of air, and look at the cardiac silhouette in relation to the spine. It's being pushed rightwards. It may be even more obvious once that pneumothorax has been decompressed and that cardiac silhouette moves back into its normal left hemithorax position. Another pneumothorax, large volume. Look at the cardiac silhouette in relation to the spine. It looks like the cardiac silhouette's being pushed to the right of midline. This is a tension pneumothorax. The other thing to consider is this patient's position. So there's an endotracheal tube. I wonder, perhaps this patient is supine. Well, how do I know that for sure? With this large pneumothorax, air is going to go into the most non-dependent aspect of the chest. It's going to rise as high as it can. And so if someone's laying down flat, think about the highest part of their chest. It's actually the base of the chest approaching the abdomen. So all the air is going to collect at the base of the chest, and it's going to press the diaphragm down. This is what we call the deep sulcus sign. If you look at this image, you actually can't see the costophrenic angle. It's pushed beyond the margin of the image. A couple pitfalls. Be careful here. Why is this not a pneumothorax? Well, it doesn't really conform to the normal shape of the lung like you see on this image. A pleural line should conform to the lung. So this is a bulla. How about this one? Do you see that line? That's actually a thin black line. It's not a thin white line. This is a skin fold. So remember, air is loosened, and even when it's trapped between two layers of skin and soft tissue, it's still going to be dark. Skin folds may cross midline. They may extend beyond the confines of the thoracic cage because it's related to the skin. So it's not really bounded by any thoracic landmarks. All right, very quickly, abnormal cells in the pleural space. Limited discussion here. What you need to remember is malignancy. So mesothelioma or perhaps metastatic disease. Here's a case of mesothelioma on frontal and lateral x-rays. Look at the right side of the chest. Look at the nodular thickened contour of the pleura. You almost get a sense that the fissure is also thickened as the pleura invaginates into that fissure. Here's a corresponding MRI image, and you see the same thing. So nodular thickening. This is really extensive malignant involvement of the pleura from mesothelioma. Metastatic disease can surprisingly look quite similar. So metastatic disease, it's not necessarily specific for any primary process, but what you see again is thickening and nodularity of the pleura. In this case, much of the disease is unilateral, but oftentimes it's bilateral. It's hard to predict. All right, so the last concept is infection of the pleural space. We refer to this as empyema. The trouble is it's often difficult to diagnose based on imaging alone, but there are some imaging clues that might help point you towards that direction. So pleural thickening may suggest inflammation. Air and fluid in the pleural space may be due to a gas-producing organism, specifically that air. You may have a rip-roaring pneumonia nearby, so if the lung's abnormal, that might push you in that direction. And sometimes the patient history helps. So was there a recent lung surgery? Was there a potential complication? Did something break down? Was something contaminated? Some of these clues could help point you towards that diagnosis. So to quickly summarize, remember, 2 layers of the pleura which line the inner thorax and cover the lung. In terms of fluid or pleural effusion, that's usually dependent. You can use CT imaging to determine the density of the fluid, and that'll help you figure out whether it's simple fluid, something complex with debris, maybe even blood. Chronic, complex, organized fluid, that fluid may be loculated, and you may see pockets of fluid in non-dependent areas. In terms of air or pneumothorax, a thin white pleural line indicates the pleura, and then adjacent lucency is the abnormal air. In terms of a tension pneumothorax, that means that there's pressure exerted upon the heart and central vessels, and you need immediate decompression. Be careful of fake-outs like bullous disease and skin folds. In terms of malignancy of the pleural space, consider mesothelioma and metastatic disease. They can look quite similar, and infection of the space is termed empyema. So with that, I thank you for your attention, and I wish you lots of luck.